So we have the last session of this fantastic meeting, and besides the inclusion criteria and patient selection, I think the follow-up is one of the most important things in focal therapy, and I would like to introduce Dr. Clements from Memorial Sloan Kettering with the reporting functional outcomes, please.
All right, well, thanks everyone, and thanks to the FTS for inviting me. In the next 10 minutes, I'm just going to talk specifically about functional outcomes, how they can be measured after focal therapy, and just focus on this important aspect of the recovery. I'm a urologic oncologist. I have trained in biostatistics with Andrew Vickers' group at MSK, and this is one of my main interests research-wise. All right, so I'll start by showing some data in the existing literature on quality of life outcomes after focal therapy to kind of motivate the rest of the talk on how we can best measure functional outcomes and some considerations with the different questionnaires to use and then how to best analyze them. So as we go through these outcomes and analysis techniques, just want to keep in mind some of the methods that are used here as we go forward. So this is an early small study from 2011 published from University College London, enrolled 20 men treated with HIFU. You can see here they used IIEF 5 scores shown on the left side of the screen. They noticed a decrease in erectile function at the 1 month time point, but no significant differences thereafter. And then you see the urinary function outcome shown on the right, where they compared at 1 and 3 months compared to pre-op, but the outcomes were similar thereafter. What I'd say about this way of showing the data is the box and whisker plots, they don't necessarily show the confidence intervals over time, and then comparing just at specific time points compared to the pre-op doesn't exactly use the longitudinal modeling to the best effect. This is a study from Australia published in 2020. This analyzed a prospective database of patients treated with IRE from 2013 to 2018. Here we're looking at outcomes at baseline 6 weeks and then 3, 6, 12, and 24 months in 84 patients. Here they're using the EPIC urinary domain, which scored 0 to 100. And while they saw a decrease at 6 months, after that time period, no differences from baseline. And then on the EPIC sexual function questionnaire, they saw a decrease from about 65 out of 100 to 50 out of 100 in terms of the score thereafter. So with that in mind, I'm going to now go over some of the patient-reported outcomes measures that can be considered for research studies in clinical care with focal therapy. So with the urinary function measures, you could choose one that's specifically designed for incontinence. This is one of those is the ICIQ, which is scored out of 21 points. And notably, it doesn't include the pad count, but it has 3 different measures of the bother of the urinary function of the incontinence and also the bother. Conversely here, the AUA symptom score, or the IPSS, this is completely focused on storage and voiding symptoms. It doesn't have any items specifically on continence, so this isn't a good standalone questionnaire, especially if you're going to, say, compare outcomes with radical prostatectomy, because it's not going to capture the continence aspect. The Expanded Prostate Cancer Index, or EPIC, it's a modification of the UCLA PCI and has a urinary domain that's scored 0 to 100. This does capture all of the symptoms of voiding, storage, and continence. However, it doesn't have as defined of a clinical interpretation as the IPSS. Likewise, there's this MSK Prostate Quality of Life Survey that it does include all those different domains as well. And one thing to just highlight, when you're comparing between questionnaires, this questionnaire has an item for occasional pad or protective material, whereas the EPIC, it doesn't include that. So just when you're combining data sets, that's something to be attuned to. For erectile function, two of the commonly used questionnaires are the EPIC mentioned earlier, and then the IIEF questionnaire. The EPIC, again, is 0 to 100, includes erectile function, sexual function, libido, orgasm, and bother. And then there's the IIEF, which this has been used since the late 1990s. It's been validated in many languages and clinical settings, and it has 6 items on the erectile function domain, which is the most commonly used part of the questionnaire. There are definitely some limitations to using this, though. It was validated specifically in men on Viagra in a clinical trial that had a regular partner, so 4 out of the 6 items refer to penetration or intercourse. So if you have a patient that isn't sexually active for a reason other than erectile function, they're going to falsely get a low score. So the way I use this is I have an added question, whether they're not sexually active, what is the reason? And there is a scoring adjustment that can be used if that's the case. So rather than just reporting the outcomes, it's good to understand the context so you can score it appropriately. I do like the IIEF because it has a very good clinical interpretation. There are these validated ED severity categories, so that's why I personally use it in my practice. Just one note on the shim. This is just 5 out of the 6 items from the IIEF. The reason that I would discourage using it is that there's a 6-month recall period, which if you're assessing your outcomes, and the patient is looking at it and filling it out faithfully, 6 months isn't a good look back period for serial monitoring. So to finish out the talk, I'm just going to give some thoughts on how to analyze these outcomes after you've collected them. You want to keep in mind, did you measure it at a single time point or was it a longitudinal analysis? You want to think about a discrete or a continuous outcome. One thing to think about, say for instance with the IIEF score, you can take the mean score, but with a very skewed outcome like erectile function, you're going to have a lot of patients that are coming in with like a score of 0 to 5, and then a lot at the higher end. So what's often done is using a threshold like greater than 24 would be potency for the IIEF, and that's going to be a lot more informative than averaging with the kind of a bimodal distribution. So sometimes it's actually better to use a discrete outcome even though you have continuous scores. And then baseline scores are very important. I would definitely recommend if it's an observational study, you want to adjust for the baseline scores, and then you may want to also exclude patients that say were incontinent prior to focal therapy, because it's going to eliminate the effect you're trying to study. In a clinical trial, sometimes it can be more efficient not to measure the baseline quality of life, but in any observational study, it's very important. And then next thing in terms of the analysis is using the appropriate type of statistical modeling, which I'm not going to get into too much, but generally the favored different modeling techniques are generalized estimating equations, linear mixed effects models. What those do is they use the correlation between measurements to give you a more precise estimate than, say, just comparing what was it at 3 months versus the baseline, what was it at 6 months versus the baseline. This can also handle some issues with missing data. And then the other part is visualization of the outcomes. I think that I highlighted those earlier studies. There is a lot more that can be done to really show your data and have it actually reflect the modeling. So for instance, these are 3 different ways of showing the same data. So if you just take each time point, fit a t-test confidence interval, you can get these error bars, but that doesn't kind of incorporate the multiple measurements, and it's, I think, visually harder to see. You can also just fit a polynomial regression model. That's what 1B is, the lowest smooth, but that doesn't take into account adjusting for confounders. So what you can do in 1C is you can take your regression models, fit a smooth term to it, and then plot that. And then you're showing exactly what's in the regression models when you're visualizing it, so it's very clear to the reader. This is one example of how we did that. So this is where we looked at over the past 10 years, had urinary function outcomes improved after radical prostatectomy. And you can see those curves there. They exactly reflect the models that are shown below for the hypothesis testing. So it's just very clear when you look at that line being flat, we didn't find that they improved over the past 10 years. You can easily see it in the figures and associate that with the models. So with that, I want to say thanks for your attention and the invitation, and just show my list of summary points. So you want to select the right measure. I think ones that incorporate both continence, storage symptoms, voiding symptoms, you're going to get a better sense comparing with other treatments. And then reiterate, it's very important to have baseline analyses. So in my practice, every time I see a patient for prostate cancer, they get a questionnaire automatically sent, and for my partners that treat it as well. So if you have that, you're going to be able to do a much better analysis. And then use the longitudinal modeling when possible. And I like the visualization of the outcomes to match the modeling to make it most clear to the reader. All right, I want to thank you.
Okay, thank you very much. So I think you made it really clear, and we all should do that. The best would be to take the same questionnaires, but I think that's a lot of work, and well, we should proceed. Or is there any question?